This is Call the Psychiatrist, the show where psychiatrists answer your questions. I'm Dr. David Handley.
And I'm Dr. Abby Snavely.
In this episode, we have two questions. The first listener wants to know how we choose between psychotherapy and medications in the treatment of anxiety and depression. The second listener became angry at her therapist and worries her therapist will end their relationship.
Say you like me, you better count the ways.
Hey, Abby, did you notice I finally got a little bit of attention on Instagram?
You didn't get my attention. What happened?
Yeah, it has nothing to do with the show. It was a video.
Oh.
It was just a video of our newborn llama.
I know. It was so cute. And you said happy birthday. And I thought it was because it was the llama's birthday. But then when I found out it was a newborn, it did kind of melt my heart.
Yeah, I should have said it's birthday. Yeah, but yeah, right.
Birthday, sure.
It's brand new. So it sounds like we need to have more llama content.
I think there's probably never too many llamas. Can you get a horn on that llama and make it match with the branding?
That's going to be part of the strategy for training.
Can't wait.
Yeah,
okay.
Llama corn
Perfect.
for sure.
Mm-hmm.
Before we get to that first question, just a quick reminder that listening to this podcast does not mean we have a doctor-patient relationship. Our intention is to educate and entertain you. Nothing we say is intended or recommended as a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your own physician or other qualified health professional regarding any medical questions or conditions. Our first question comes from Diane.
I'm curious about how, as a psychiatrist, you treat depression and anxiety. How do you evaluate when the condition or conditions should be treated with medication and when your patient should be treated with therapy? How do you know when the cause is a physical or chemical problem and when it's something from the patient's past? Are there predictive success outcomes with either approach?
So this is a great question. Mm-hmm. Researchers have been asking this question since the mid-1970s. And, honestly, the answers aren't that satisfying. And one reason for that is that it's really hard to study psychotherapy.
Yeah.
If you think about an ideal study, you have two groups that are essentially the same. One group gets the treatment and the other group doesn't. And then every member of the treatment group needs to get the exact same intervention. So how do you make sure that every subject in the study gets the same psychotherapy experience? So you can kind of see where the problem is.
Well, especially when we know that the fit between the individual therapist and the individual patient is one of the best predictive factors and if the therapy will be successful.
Yeah. But what researchers did in the 70s is try to come up with some type of manualized therapy. So something that would be time limited, like 12 to 16 weeks, that could be replicated between research therapists. And this is actually where we get interpersonal psychotherapy. It was an attempt to standardize some of the concepts in psychodynamic therapy. And I'm sure some of our listeners will know Aaron Beck is the author of Cognitive Therapy, later Cognitive Behavioral Therapy. And he had been working on that in the 60s, but he had yet to manualize it, again, to kind of make these scripts and things that could be used in research. Did you know that I was a CBT therapist in a study?
I did not.
Yeah.
How was it? How'd that feel? How'd it go?
Well, it was with teenage boys, so it was hard.
Cool. Was it for substance abuse or no?
Yep. Substance abuse.
Okay.
But I thought it might be useful. You're thinking about how do you study therapy. So you get this 3-ring binder detailing the content of every session, and then your sessions are audio recorded, and then somebody scores your sessions to make sure you did everything you were supposed to do. But that
sounds tedious.
It is, yeah. It makes you honest, though, about being faithful to the modality. But one thing that I took away from it is that while I could standardize the content of a session, I could tell after a couple of sessions whether the kids were going to get something out of it. If we weren't clicking, kind of back to what you were saying about how important the relationship is. And I know that a researcher would say, but yeah, everybody's randomized, so the therapist next door will statistically have a similar failure rate. But I thought it was interesting because, again, like that most essential part of treatment wasn't getting captured, the relationship, the rapport, or the alliance, whatever you want to call it. And so
including your ability to sort of be flexible or react in the session to what worked for each individual patient, right? Because when you say you could tell what the kids were going to respond to or not, you were not saying that all of the kids liked the same intervention and disliked the same other intervention, right? You're saying it varied from person to person, how they would respond?
Well, no, I could tell whether, did we have enough of a relationship that they were going to be willing to even give a lot of it a try, whether they were shut down or whether they were engaged.
But for some
whether they
kids,
liked
they
me.
engaged, and some they didn't, right? Like,
Yeah, some
I mean,
kids.
obviously, you're not everybody's cup of tea. Let's be real.
Yeah, right.
Okay.
Especially kids.
Oof.
So when you don't have the relationship, then it just felt like I was teaching a seminar to a very surly audience, but a seminar just you're just like teaching. I was just teaching without a lot of the therapy part that went into it. So anyway, I just I guess
So
back
then probably
to
not being a very good teacher, right? Because you don't get to really react to how well your student is taking in the lesson. And for some kids, did the 12 weeks do a lot? I know that's sort of beside the point, but I'm curious.
Yeah, I think so. I mean,
okay, cool.
It was again, it's their research. It's a research study. So there are a lot of external incentives, and we're paying them to be there. So it's not real world. That's for sure.
Okay, fair enough. I know there's so many comments, but I'm just going to bite my tongue. We have a lot to cover.
Yeah. So that gets us back to, okay, we're trying to find out what's the evidence for what you should do. I can summarize 40 years of research. If you can manualize a therapy, you can study it. And the manualized therapies have shown benefit in treating different anxiety disorders and depression. So therapies like exposure therapy, dialectical behavior therapy, cognitive behavioral therapy, interpersonal therapy. You can't actually say there's scientific evidence for the benefits of psychoanalysis just because you can't study it in that way.
There is a story, and this is anecdotal. Well, it's someone else's anecdote that I'm repeating. So some telephone phenomenon's happening here. But allegedly, the NIMH, the National Institute of Mental Health, tried to study psychoanalysis where they recorded all of the sessions. And apparently the project was abandoned pretty quickly because it was so boring and like drawn out that they like nobody could even stick with it long enough to figure out what they were studying. So whether that's an urban legend or not, I don't know, but it gets repeated.
Yeah, I can see that.
I could see it too. Well, especially, right? The therapist's not saying much. You're listening to the patient free associate in that classic way. And so if you're looking for specific therapist interventions, it's like therapist is silent, therapist is silent. Anyway.
Right, and if it's not standardized, you can't compare the outcomes. Like,
well right, because then we're talking about people's unconsciences or in communicating, and then we run into some serious problems in reproducibility.
Yeah, right. All right, so let's just say that we have evidence that some therapies work, that they can be effective. At least they're better than nothing. They're better than placebo or routine care.
Sure.
And then maybe the next question is, do medications work? And I mean, I think definitely maybe.
Well, and again, but are you talking about individual people or are we talking about on a population level?
Yeah, when you lump everybody together, you get a modest benefit compared to a placebo. It's not overwhelming. It's a little bit. It's okay. And if you compare that to therapy, it may be the same effect.
And what meds are you talking about here?
Yeah, antidepressants.
Antidepressants. So keep going.
Okay. So if you then compare antidepressants to therapy in some of those studies, oftentimes they seem to have similar effects, but in other studies, the therapy has an advantage. And then we have some other studies saying that the combination of the two might be better than either of them alone.
I feel like that's what gets repeated.
That's what gets repeated, but then, more recent research is not necessarily holding true for that. So,
right.
Research is not clean. I mean, you
especially
get positive findings and negatives, and especially in this area.
And then we also have these rating scales for symptoms. And a lot of times, I would assume in your study and otherwise, patients fill out these self-report questionnaires, or the clinician can ask the patient about their symptoms. And then a lot of times we say, this medicine or this therapy was effective if a person had a 50% reduction in the numeric score of whatever rating scale is being used, right? So usually they're taking a total, so we don't necessarily know which symptoms are better treated versus others. We also, a 50% reduction if somebody is really depressed might leave them, feeling a lot better, but still with significant impairment, or someone with mild or moderate depression with a 50% reduction might not really notice a difference. And often I don't think that people are necessarily rating their quality of life or things that are harder to measure than the hours or quality of your sleep or how rested you feel or things like that. I guess we have to ask ourselves, ask our patients, and be realistic in terms of what would be the goal of any of these treatments anyway, right? I mean, that's probably a bigger discussion. But if somebody says depression, what are they actually talking about? And is it realistically addressed with either of these interventions?
Yeah, just because you look better statistically doesn't mean that you're actually better.
Right,
Yeah.
like at all. And again, and I don't think we're always talking about the same thing, but I know you wanted to say more about that.
Yeah, I mean, I think that's the big problem. I mean, again, when we talk about modest effect size, it's with all comers, and I don't think we're always talking about the same thing. Are medications overprescribed? I think almost certainly they are. I got into this in episode 6, I think, about bipolar overdiagnosis, about pharmaceutical companies and how they advertise to patients and doctors, and how they made it seem like many hard times could be easily treated with medication. But, I also think that anti-psychiatry nuts sometimes make really good points. Like there's nothing that critics say that I haven't thought about or can't find something to agree in. But what I do think the problem is the idea that we put everybody together as if we're talking about the same thing. And I think these illnesses are so heterogeneous that, they're probably not even the same thing. But if they are, we need to at least be careful about who we're talking about. If somebody wants to criticize medication use because somebody's sad because of the context of their lives, should they also be criticizing medication in somebody so depressed they're psychotic? They can't eat or drink, that they think their insides are rotting or they're catatonic. The critics never acknowledge that latter patient. They don't acknowledge the people that are so manic and psychotic they're eating their own feces or cutting off their body parts. And they want to say that we're monsters, but they never acknowledge the actual suffering.
Right. And so if we are, but in your case, right, if we are prescribing the same medicines to someone with a psychotic depression, again, thinking that they're rotting from the inside out or that they're evil or they literally can't get out of bed or use the toilet, and those are lumped together or treated the same as someone who critically is called like the worried well, right? Or somebody that's a little bit neurotic or slightly anxious when maybe you should be anxious in the world. I mean, I know that's exactly what you're saying, and I'm maybe not saying it any differently or better, but it's like for some patients, medications are absolutely indicated. And just because you can find and name a lot of people who maybe could get better with other sorts of interventions. Exercise, for example, is effective for mild to moderate depression. And I think a lot of critics would say, well, and that has far fewer side effects than, and nobody's getting rich off of a patient exercising.
I think we're trying to, it sounds like we're walking a line too. We don't want to say that just because you have mild depression and you want to take an antidepressant, there's nothing wrong with that if it's a benefit to you.
Of course.
If when you weigh the side effects and maybe the benefit and it comes down in your favor. Again, I'm not being critical of those people, but I understand where the critics are coming from in terms of pathologizing human behavior.
Right.
But I also want them to acknowledge that there is real pathology too, that there are severely ill people, that it's not some social construct.
Well, right. I mean, yeah, that these can be parts, suffering is part of the human experience. Sometimes feeling down or blue, feeling anxious is going to be part of any person's full human experience. But there is a place where that crosses over into pathology. And I don't think that someone who can't function in their life at all is really going to be very receptive to the idea that, yeah, this is a social construct and we should really just be tolerant of the people who are soiling themselves in their beds and can't eat and, are cachectic and causing severe harm to their bodies because of their deep depression in that case.
Yeah, or that we've made ourselves the arbiter of what's normal and abnormal. And again,
right.
There is some...
folks, I say this all the time. My range of what I will consider normal is huge, right? For me to say this really falls outside, it's a wide berth. I mean, people can be as weird as they want to be. I mean, this is not, again, and I think most psychiatrists are that way. We are not typically people that have a real straight and narrow definition of what normal looks like. I mean, I think most people would cringe even at the word normal.
Yeah. And then I also know there are people that they're happy to try to medicate anything. I mean, depending on the context and the amount of time they have.
Do you see that in other psychiatrists though, or do you see it in primary care?
Well, more in primary care, but I didn't want to, I wasn't going to single them out. But yeah, it's kind of, it's in that model where it's like, we got a couple of minutes. Here's a problem I can't really address, but if you want an antidepressant, you can give it a try, see what you think.
But I mean, I guess I think it's worth pointing out primary care, not to criticize them or throw them under the bus per se. I mean, there is a part of like, it feels like you're doing something, right? A patient is coming to that doctor with suffering. And then there's also a part that these people in general have to exist within the system that requires 5-minute or maybe 10-minute appointments. And maybe they'd do better to refer to a psychiatrist if they can, or a therapist. Maybe there could be some education or empowerment to be able to say, oh, this sounds like something that you should talk to a therapist about, and a medicine's not going to help. But if a patient is in there, you have 5 minutes, they're asking for something, and you can offer something that you think has a chance of helping. And, also a lot of times has a pretty benign side effect profile. Like, I don't think it's because those primary care doctors are evil or greedy or arbiters of what's normal. I think most people want to help. And there's a lot of pressures of the system and otherwise, the system, the patients, et cetera, that make it really hard to do a sophisticated assessment and counseling session about what's really indicated here. Yeah, and most of these meds are prescribed by primary care, which is also why I think we have to talk about it. And in the anxiety and depression realm. And
the patients also ask for it. And
that's what, yes, exactly.
Antibiotics for viral illnesses, or and it's part of it is like, I've got to do something, otherwise they're going to write a negative review about me.
Right, absolutely. And there's been this, and you should take this out if it's poorly timed, but there's been this whole effort on behalf of our profession to medicalize these illnesses and gain legitimacy as on par with other types of medicine. And I think it becomes very popular, or has become very popular, to say, well, if you had diabetes, you would use insulin. If you have depression, you would use Prozac or whatever, right? I mean, like, these parallels have been drawn that don't really hold up, but I think also have been successful in convincing the public that these are, often convincing them that these are, medical illnesses like anything else, which in this current medical culture usually does involve a pill.
Yeah. And you know what? Some of them are neurological problems, and
100%.
Some of them aren't. and that's what I mean is, we can't have a discussion without defining who we're talking about. At least a discussion where, where like, again, some of the criticism is appropriate if applied to the right population. Some of the criticism is ridiculous because clearly they've never actually seen sick people.
Well, and, a lot of people, if they didn't do a psychiatric residency or work in a psychiatric hospital or emergency room, probably haven't seen people that sick.
Yeah. Well, I had an example I was thinking of, something less graphic, just with OCD, because we
I know, but I do think it's worthwhile to say, like, these are life-threatening illnesses, and we're not just talking about suicide, right? Like, it's fine to be, I think it's fine to also be less graphic. I'm into that. But I think in that way, it does hold up alongside at least some other medical illnesses to say, like, this really impacts somebody's morbidity and mortality.
What if I say a more accessible example?
No, you can say that. I'm not even trying to argue with you. I'm just trying to give an impassioned plea for the catatonics of the world.
Yeah, well, I know I mentioned a case that I will always be in my mind of somebody eating things that weren't food. But anyway, I was.
Oh, yeah. Okay. Yeah. But people eat all kinds of stuff. Is my point. This is part of.
We've had issue. We've had millions of years of evolution that helps us not to eat our own feces.
Right.
Like, in order to do that, you've had to overcome most of your brain.
Yeah.
The most primitive parts of your brain.
The primitive biological instincts and urges.
Of self-preservation have gone offline. So.
Right.
I don't know how much of that I can even put in there.
I think hopefully a lot. But you had an OCD patient you were also thinking of?
Well, no, I wanted to use this as an example of the meds versus therapy.
Okay, great.
Which is that we can take obsessive compulsive disorder, we lump it in with the anxiety disorders. But if there ever was a brain problem and not something socially constructed, I think surely we could agree that severe OCD falls into that.
Yeah.
Now, I would say that exposure therapy is probably the best treatment as far as getting a really good response compared to medications. The benefit is durable, meaning it lasts a lot longer than medications, a lot fewer side effects. But then there's people whose symptoms are so severe that they can't do the therapy.
Yeah. How do you even participate?
Yeah, they
Right?
can't even get to the office
Because
it
when
takes
you're talking,
5
right,
hours to
it's
drive
an
around the block.
exposure therapy where the person is exposing themselves to the thing that they fear or that they believe is going to, that they or their loved ones are going to befall a horrible fate if they don't do it. Like that's a big barrier to overcome. And that's also an illness that, we don't really do a lot of psychosurgery these days, but that's also an illness that sometimes requires brain surgery to, do the anterior cingulotomy and give somebody some relief. So that's probably about as concretely biological as you get.
Yeah, we should probably do an episode on DBS too.
Yeah.
But the point I was going to make is that sometimes, so we know therapy is great, but sometimes medications can reduce the severity of the symptoms a little bit. It doesn't cure them, of course, but it can make them able to function so that then they can tend to their lives and then make use of the therapy. Yeah. And then at some point in the future, you can come off the medications. Like it's not an either or, but a both and in that regard.
Correct.
Well, so the official recommendations, and I think this is, maybe it's what we're saying already, but the National Institute for Health and Care Excellence recommends that if you have a new episode of less severe depression, that a person be offered psychotherapy unless they prefer a medication, and that people with more severe symptoms are offered a combination of antidepressants and psychotherapy. So, the problem is where you're going to get psychotherapy these days, because it's actually kind of hard to find a good therapist sometimes.
AI app or something, right?
Yeah. Well, there was one study, 70% of patients newly diagnosed wanted to do cognitive behavioral therapy, but only 25% actually did it. Mm-hmm. Some of that is probably has to do with cost, because your insurance policy gets reviewed every year. And so it's all about short-term cost. So we know medications are cheaper on the front end, like in that first year or so. But there was this really interesting article from 2019 in the Annals of Internal Medicine showing that, yes, that's true for the first year, but if you actually go out for 5 years, the cost effectiveness ends up being about the same when you look at other quality of life measures.
Nice.
Yeah, but again, insurers aren't going to be looking at their 5-year turnaround.
No, they're not into that. How do you talk to your patients about this, though, Dave? Do you cite this recommendation? What do you actually say?
I try to be realistic. I try not to promise things that aren't true. Mm-hmm. I try to talk about, there's certain people, I do recommend it pretty strongly because they're suffering so much. And they're usually the most reluctant ones to take anything. Especially if it's anxiety, right? Yeah.
Anxious people turn out to be anxious about taking a medicine.
That's right.
As well. Well, seriously. And I don't know if that points to severity. Again, I think it depends on how you measure it. But I think often when someone's depression, let's say, is severe enough to impact their sleeping, their eating, their concentration. I definitely don't have a pill to fix somebody's marital problem or make them like their job better. But if as you said, if your biological instincts are being disrupted by this illness state, then I think that's a time when I might more strongly recommend a medication to help get that stuff back online, including, like you said, cognitive symptoms so that a person can participate in therapy. Also, in terms of dividing the medications and the therapy, I also think it's a false dichotomy, even biologically speaking. I 100% get where Diane is coming from when she says, how do you determine if this is a physical or chemical problem or something from a person's past? That's a problematic concept because trauma, different environmental factors in someone's upbringing, those change your brain, just like psychotherapy changes your brain, right? We have studies looking at brain activity, and therapy is another way to change a person's brain. Again, if you can get there and do that. So, they can obviously be targeted at the same symptoms or what we call the same problem. But I think in some ways, the medicines and therapy can also yield very similar results.
Do you want to segue into that article that came out this summer?
Yeah.
This article comes out in Molecular Psychiatry. It gets picked up by all of the major news outlets in London. And then from there, it just spreads everywhere and on through social
including the
media.
British Medical Journal, which is a major publication.
Right. Well, they're publishing rebuttals, and then Nature gets involved, and you've now experienced this with your patients. So I think it's pertinent to Diane's question because she did ask about that dichotomy. So do you want to summarize a little bit, or what your thoughts are?
Sure. Yeah. And this came onto my radar because of patients and also because of non-physician therapists I know. But it basically says decisive blow against, that's probably one of the news articles, decisive blow against the serotonin hypothesis of depression. What I was hearing from patients and what the therapists were worried about is that, does this mean my meds don't work? Does the fact that this study showing that a previous model of how antidepressants worked is inaccurate, does that mean that these meds are worthless? Which again is such a wild idea because it's like, are they working for you? If they're working for you, then I mean, we, as scientists, we care, and it probably matters for research and otherwise. But I think it maybe is part of the news coverage, the media coverage, but also, again, a problem with how mental illness and the treatment of it has been sold. And if anybody ever thought that we really understood what was going on with depression, let's say, and knew how these meds worked, then I don't know where they got that idea, because that was never part of my training, any certainty around this.
Yeah. And, the article didn't even say that, but the lead author said that in further press that she got for the article.
See, I didn't even know where it came from because people were telling me it came out of the BMJ, it came out of Nature. So what did the actual study say?
So it was trying to see, has there ever been any credible evidence of the serotonin hypothesis, that depression is mediated by some deficiency of serotonin, because that's what people go around saying about SSRIs, that because they're working on the serotonin system, that this is all linked together. And that's where some of these ideas of the quote unquote chemical imbalance came from. The author went on to say, again, not actually in that article, that antidepressants don't work and you've all been sold a lie. And so people reacted with lots of emotion around that. The article itself was just kind of like a so what, though. I mean, there wasn't like a smoking gun.
I even, looking into it, I don't know what it changed, right? I mean, even, 15 years ago, it was like, well, this works on the serotonin system. But even the idea that it's about serotonin levels. A patient might come in and say, they tested my serotonin levels and they're low. And it's like, no, that's not how that works. I mean, that is the amount of serotonin in someone's, we looked everywhere, right? Like blood, CSF, urine, probably feces to, stick with the theme, does not predict or indicate the level of their illness. And so knowing these medicines worked on the serotonin system, I think didn't ever, I don't know that anybody credible was coming out and saying, we know exactly how these worked, right?
No, right, yeah. Those studies were looking at the peripheral, indirect measures of serotonin.
Sure.
And nothing was it was just like, you were supposed to read those and be like, that's interesting. I wonder what they'll come up with next. It wasn't.
Right. Maybe it's receptors. Maybe it's, something else. Maybe, right.
And I guess, I don't know, maybe this is too far in the weeds, but maybe for education for people that like to read studies. So that article was an umbrella review. And so what happens is there will be some small studies that don't have a lot of correlation. They don't have much conclusion because they're small. Maybe they're not very well designed. And then there's a meta-analysis where they'll try to clump together a bunch of little studies to see if there's more of an effect size. And that would be okay if every study was done the same way. But the old phrase, garbage in equals garbage out, meaning that if your source material wasn't that good, smushing together a bunch of crap doesn't give you gold. And then this article tried to smush together all these different meta-analyses. And so with some exception, there was a modern genetic study that was pretty decent. But for the most part, like they were taking so what studies, clumping them all together in this big review saying, well, see there's no evidence. And it's like, right. I don't know who was saying that there was. At least
So
not
it's
from
just
what
like
we've done
it's
so
a bigger
far.
so what, right?
It's a bigger. It's like, thanks for summarizing it for us, because I mean that's helpful historically to get that perspective. But the way it got then spooled out,
Sensationalized. I think
yeah,
wild.
right.
Yeah.
Because people are like, I've been lied to my whole life,
Yeah.
or people
So
feeling
upset.
or people that actually have benefited from medications and feeling invalidated because
Right. Like, oh, it
all
was
these
all in
other
their
people.
head. It's only just, it's a decades long placebo effect. Right. Because, and again, that you got placeboed out of laying in bed all day to being, totally functional.
I mean, placebos are powerful.
Listen, an effect's an effect. I don't actually care how somebody gets there, which is also, maybe my problem here because, so what? Okay, cool. That's interesting. Maybe we'll figure it out one of these days. It's not the point.
There's a similar story with Thorazine, which maybe I'll tell it. I'm more familiar with this story than the story of serotonin, but
okay, I'm listening.
Okay, so the first antipsychotic, when that was developed, they were looking for a new antihistamine or a nausea drug. And then it finally is released, and then it starts being used for anesthesia in conjunction with some other drugs. And then it was finally noted to have an impact on people with psychosis. Okay, so then a decade later, we're now, it was discovered in the 50s, now we're in the 60s. It was seen that among other things, it was binding to dopamine receptors in the brain. So then everything you just work backwards. You're like, oh,
yeah.
Well, so I wonder if by reducing action of dopamine, psychosis must have to do with dopamine. But that drug binds to dopamine receptors, serotonin receptors, histamine receptors, acetylcholine receptors, alpha adrenergic receptors. But the parallel I was trying to make with serotonin and depression is that, so people made the assumptions working backwards, and then they tried to design studies to test the assumption. And that's kind of what has been going on with serotonin. It's like, okay, the drugs kind of worked, so maybe it has to do with this particular neurotransmitter. So let's see if we can now measure that. And the reality is we can't measure it because it's really hard to do.
Yeah, because again, I think that is a sobering truth that we're doing the best we can, but at the end of the day, we don't actually know all that much about how this stuff works.
Yeah,
and that's just true.
What we don't know is much greater than what we do know.
And we know more and more of what we don't know all the time.
Yeah. And it's intellectually lazy to think that anything about this is black or white.
Right.
But I don't know. But not knowing doesn't mean that things aren't real.
100%.
So I just think some of this you should read and just say, oh, the wonders of the brain.
Right.
This will add to the knowledge that someday we'll figure out. I don't know. All right. So we've been around the block. What do you think? Have we over-answered Diane's question?
I think that we have done a decent job of at least making an impression that this is really complicated and that it is highly individual. Maybe we didn't do a super in-depth explanation of, how do we evaluate when somebody's condition should be treated with medication or therapy. But I guess it's a big, it depends. I don't know. How do you think we answered our question?
Yeah, not very concisely.
Well,
you're right.
Is that what we're going for?
Rarely.
Right.
Yeah, I was just trying to balance we don't want to discourage people that need help to get the help they need.
Right.
We also want to acknowledge our ignorance and recognize that two things can be true simultaneously. That sometimes things are overdone, but that doesn't mean that there's not still real illness.
The end.
All right, let's take a break. And when we get back, we'll hear from Helen about getting angry with her therapist. Hey, a big thanks to everybody who contacts us. We really do appreciate it. We wanted to share a 5-star review from Melissa. My favorite new podcast. Thanks for sharing your expertise for people like me who are new to therapy. You're both so compassionate and smart. Your patients are lucky to have you. Would love to see your review wherever you listen to podcasts. Thanks. Our last question comes from Helen. Hi, I've got a situation with my therapist that perhaps you can help me address. I had an intense therapy session where we discussed a topic we've been working on, and it touched a nerve. I got very agitated. Worse, the anger stayed with me long past the session. Later that night, I sent off an email expressing my feelings to her. It was hot. She's always said emails are okay and usually responds with soothing words of comfort, but this time there's been no answer. The silence is deafening. I'm so worried that my actions have destroyed what until now has been a warm and caring therapeutic relationship. In fact, I'm now doubting that she ever loved me at all. Today, I'm feeling even more shame and feelings of rejection. I'm trying all the self-soothing actions I know, deep breathing, a hot bath, Tai Chi, but it's just too much. I emailed my therapist again, asking her if she ever loved me, with no response. I'm so scared that she's going to cancel our sessions and terminate me. What can I do?
Oof, Helen, this is so much. I can feel the pain. I get it comes through loud and clear how difficult this period of time has been after that session. And so I want to empathize with that. I think there could be a lot of different things going on. So maybe just up top, I also want to say we're going to do a lot of guessing here.
Can I start with some advice right away?
Yeah.
All right. Emails and text messages are not for hot topics.
No, that's a life lesson.
Because that's not just with your therapist. Yeah,
Right?
that's everywhere.
Uh-huh.
At least not if it's somebody you want to have a continued relationship with. Like, it might be okay after you've had a breakup and this is your final message, or maybe your resignation letter to your boss. But if you care about them, you really don't want to email or text when you're upset. Now, it'd be okay to email, I was angry at our last session and it stuck with me. I'll be glad when we can discuss this more. But I don't think I would go beyond that. I think even if she was going to email back, that's probably about all I would say.
I mean, I am curious because she said that in the past, she gets kind of soothing words back from the therapist in this context. But I wonder if it's usually more sad than angry, or something that's a little bit either lower in volume of heat, because she said it was hot. Or, so I guess it's not volume of heat, a lower temperature, or, or like I said, sadness, or something that is just on a human level, maybe easier to receive and respond with empathy.
Yeah, I think the therapist was having an emotional reaction.
Yeah. That's for sure.
Yeah. And I think there's probably some fear that she didn't want to fan the flames of Helen's anger.
Mm-hmm.
Now, I think the therapist could have replied and just said something like, I've gotten your message. This is something we should probably talk about at our next session.
Right.
But, by ignoring the email, she said something, either she's taken aback, she's hurt, she's angry, or she just wants to set up some more boundaries about email communication.
Which, again, I can also get why from Helen's standpoint, that's tricky if it feels like the boundaries are suddenly changing.
Yeah.
But yeah, I mean, I think it's all of it. And, that all being said, maybe, the therapist not responding is better than responding in anger, right? I mean, I don't know. Mm-hmm. Or from upset. But yeah, I feel like I would probably give some reminder that, like, I'm still there and that I welcome her back to talk about it.
Yeah.
But I guess it depends on, how hot did it really get? Was it personal? Was it nasty? I don't know.
Yeah. Yeah, if it's starting to threaten the relationship, I don't know. Like I say, I don't think there is a right or wrong on the therapist standpoint, but I do think...
No, we're just guessing.
Yeah, I feel certain, though, that this is going to be addressed because there's so much packed into that email that you're going to have to talk about.
Yeah, I mean, there's no other way. There's no other way. And it sounds like Helen says that she expressed her feelings. I don't know if Helen also said that she wanted things to be repaired, right? That she's really angry but wants to come back. I mean, she wanted something specific from the therapist, it feels like. But I also don't know what was communicated in that email, because if it was just more rage, I could also understand how that's hard to figure out how to respond to.
Well, one thing that got communicated, because it's in this question, is a fear of rejection, a fear of abandonment.
Right.
And so that's what I mean.
So that kind of got acted out.
Yeah. So it got acted out in the email. And so you're going to have to take that into the session. I mean, there's something about the fear that I expressed anger and now you're going to abandon me, probably maybe looking at where that might come from, or some fear that no one can regard me unconditionally. Or does Helen test relationships like this? Does she sabotage things by her anger? Or, maybe it's none of those things. I mean, this is all speculation, of course.
Sure.
But maybe there's just something to learn, that relationships aren't either or computations. They're not black or white. They're kind of messy. I can have a lot of negative emotions about somebody. Frustration, disappointment, anger, being shocked by some nasty email, and simultaneously still care about them.
Absolutely.
And so I think her therapist is entitled to have a full range of emotions. She's probably not going to act on them, but I think that could be very helpful for Helen to understand what that's like, that it's not so either or. It's not either you love me or you hate me.
Right. No, I mean, yeah, I think that is all fair and reasonable, worth considering. Obviously, these two women have a real relationship as well as a therapeutic relationship going on. But I think for Helen, it would be important to ask herself, kind of like you're pointing out, Dave, is some part of this a pattern with other important people in Helen's life? And I say that not to say that what happened between her and her therapist isn't real, because again, it is. But sometimes when things get extra heated or heated, emotional in a way that is hard to understand or feels like a really big reaction, again, a real reaction, I'm sure Helen is going through a lot, that could be because this is some sort of enactment, that this is a repeat unconsciously or outside of her consciousness, that not only is it the rejection of the therapist, but adding on to that, behind that is the rejection of all these other important figures in her life. And so, whatever the quote is that, hysterics, not that I'm calling Helen hysterical, but that hysterics suffer from remembrances. If this feels big, it's probably because it's also based on past experiences. So I don't know. I don't know if you have more to say about that.
No, I had a question for you.
Yeah.
So you mentioned in an earlier episode, I can't remember which one it was, that you had this irate patient because you were pregnant. And we just quietly said, well, of course he was so jealous, but
Right.
he was so angry and he was all F you and F your unborn baby. And you were so nonchalant in telling the story, but this question reminded me of that because I mean, surely you had some other reactions or something else that you were feeling. I realize you handled it well and you moved past it and
Sure.
that person did fine. But I was just thinking about Helen's therapist in this scenario and imagining that you may have had a lot of feelings going on when somebody's saying those things.
Oh, yeah. I mean, absolutely. I think that, probably in the session, if I think back, it was upsetting. It felt very aggressive, obviously. Probably not hard to imagine that I felt protective of myself and of my baby. I think that sometimes there can be more of a conflict, maybe even paradoxically when it's more subtle about where my loyalties might lie or what's going to happen. But I kind of think, in the session, it was super intense, but then maybe afterwards, it was pretty easy to say, well, okay, this guy's jealous, but if he's literally asking me to choose between my soon to be infant and him, there's no contest, right? Sometimes, maybe I'm struggling like, oh, I should stay at work or I should add another patient or should I come home to my children that are older now? But I think it was like such a hard attack that I felt so protective that it maybe didn't get to me as much as something that might feel more personal or wasn't so clearly just about him, right? Like so in your face that it was like, wow, this really is all about you because you're not like you're so upset. You're not thinking about me at all or this relationship at all.
Yeah, that makes sense. Yeah, it was.
I know that's not the answer you're looking for.
No, it makes sense though because it was so absurd that it was easier to be distant from it. I mean, I've had somebody who routinely sabotages relationships and then not surprisingly tried to sabotage their treatment.
Right.
And then assumed if they behaved badly enough that I would abandon them. And yeah, it almost worked. I mean, because you do get worn down after a bit, but that was harder than like what you're saying. Sometimes when it's so over the top, that it's actually easier. I mean, if you're screaming at me and calling me names, but you also happen to be naked in the hospital.
Right. It's like, who's more vulnerable here?
Yeah. Right.
Whereas, the other time, I mean, I think definitely people get angry or yell or cry or things like that. That's a little bit easier. But probably when I get more mad is if something does get under my skin or if I get dragged into something, which is another hypothesis I have actually about Helen in this, that I guess the concept I would use is an enactment where I end up being dragged into doing something that I wouldn't normally do, or like making a concession or going over. And again, I'm not saying the person's doing it consciously, but that where I feel manipulated, that will make me mad, which maybe just maybe says more about me, or people might act out around payment or times or things like that. I tend to do a lot better when the actual issue is on the surface rather than when it's being displaced and people are saying, oh, I just didn't write it down in my calendar, or, and that's when I showed up at the wrong time, or,
if you know where they
whatever
stand,
that
if they're
is.
being honest with where they stand, it's easier to address for sure. So I guess maybe back to Helen's situation, I don't think that Helen's going to get fired over this.
No.
In fact,
definitely her therapist is thinking about her.
Yeah.
I mean, for better and worse. I shouldn't say definitely, but almost definitely. Yeah. Because if I didn't respond, I would be thinking about responding all the time.
Yeah.
Right. Yeah.
And there's so much reaction to whatever happened in that session. And now these emails and that fear of rejection, that I think the therapy is actually about to take off. Like, I think this is going to be a moment where things really start happening for Helen. So that's why I don't think she's going to be terminated. I think this is ultimately going to be a good thing. They're going to deepen the treatment.
Well, and I mean, I guess another point here, the word love comes up a couple times here. Did she love me at all? Did she ever love me? Asking, do you love me? Kind of demanding reassurance that she's loved. And that is such a human and basic need to be loved. But I also think that, love is a tricky word. And so I'm very curious if, has the idea of love or saying that they love each other come up in their treatment or Helen's treatment previously, or is this a demand she's making or a question she's raising over email for the first time? I mean, I think, there's different types of love, but I think that it also, just that concept adds another level of weight or heat to it that I don't know, that I'm just curious about, like, how that gets untangled.
Yeah, it feels intense. I'm not sure
so
what that means
intense.
Either. Also,
I mean, it's not like, do you care about me? Do you love me?
Right. Have you ever loved, or did you ever?
Have you ever loved me? I mean, those are, dramatic movie words.
Yeah, because I wonder if her therapist is going to say, well, maybe not in the way you thought I should, or in a way that I can.
Right. Because I think there is a fantasy about what that love does for Helen or means.
Yeah.
That probably isn't going to be fulfilled by anybody.
There's a lot of good stuff here. We're looking through a pinhole. And so
I know.
If Helen, if you, or anybody for that matter, if you want to let us know any follow-up or how it goes, if we're onto something, if we're way off, feel free to let us know.
Or just add to it, because it's all guessing.
Yeah. Yeah.
Right.
All right. Thank you, Diane and Helen, for taking the time to send in your questions. And we thank all of you for listening. Please send in your questions by email or an audio message at our website, callthepsychiatrist.com. Also, if we answered your question on our previous episode, we'd love to hear from you. You can even come on the show and tell us how wrong we got it, or maybe how right we got it. We'd also love to see you on Instagram and Facebook at Call the Psychiatrist. You can see the new baby llama, Daryl Bunny.
I was going to say, check out that llama, if nothing else.
Right.
Pop on over to Call the Psychiatrist if you have time.
And if you've gotten any benefit from the show, we'd really appreciate it if you would write a review wherever you listen. Thanks. Take care.
Bye.
Okay.
I just didn't know what story you were going to tell. I thought it was going to be a more interesting one.
Yeah, sorry.
No, to me. Not right, but no, that was mean.